So I will keep on going with the agenda so that we don't lose a ton of time. I'm going to turn the second half of this panel conversation back over to Mr. Marvell Terry.
Good morning. Good morning. How y'all feeling? Y'all all right? Awesome. Awesome. This panel is about urban perspectives. As we heard earlier in the day, we received information and insight and recommendations from our rural perspectives. And now we're going to hear from our urban community members. Civil rights activist and vice chair of the Mississippi Freedom Democratic Party said during the Freedom Summer of 1964 at the Democratic National Convention in Atlantic City that she was sick and tired of being sick and tired. I am almost certain that that is the sentiment of many of the activists, of the leaders, and many of the individuals who do movement work in Texas say every single day, that we are all sick and tired of being sick and tired. As we hear about our urban perspectives, we recognize that the urban definition is very broad in its scope and its perspective. We will hear from our panelists who have committed to ending the HIV epidemic in urban communities. This includes communities who are often over-policed, communities who are experiencing unemployment or underemployment, and live in an urban area where the skyline is to rival where communities in the shadows of the skyline search for what's left. So now I would love to hear from our panelists. If you could tell us who you are and what does your agency do in the urban context?
Good morning. I am Marquise Prince, Chief Program Officer for Abounding Prosperity in Dallas, Texas. My agency provides testing and services to the Black and Brown community in Dallas. We are located right in the heart of South Dallas, right off of MLK, spanning across 3 different buildings on that particular street. What we believe in is that we must approach each and every one of our clients in a holistic way. So for us, it's not just about HIV testing, it's about food pantry, it's about housing. We offer housing, food pantries, clothing drives. We offer wellness spaces. We offer substance abuse counseling. We offer mental health counseling. We offer an array of different support groups for each individual, our transgender women, our Black women, our YMSM, our MSM, our Black men, our parents to those YMSM children, and also educators who are educating our students as well. So we offer an array of services that build a unity and bond in the community and fulfill a need that's typically overlooked. We believe that before we can talk about, at Abounding Prosperity, before we can talk about any health disparities, we must fulfill the need that's at hand. And I think that we've been doing this now for 19 years. We're going on our 20th year of service in Dallas. When we started our organization in 2005, we had no funding, no federal funding, no state funding. We started by selling donuts and washing cars because we believed that we had to take care of us. Our founder and CEO, founding CEO, Kirk Myers, believed in that if no one else was going to take care of our community, that we needed to take care of our community. And we built on that over the past 19 years, getting us to where we are today, able to reach thousands of people yearly, able to house hundreds of people yearly, able to feed and clothe hundreds and thousands of people yearly right in the heart of Texas. So I'm thankful for being able to speak to you guys today and answer any questions, and just look forward to this today.
Good morning. My name is Jay Picano, and I just wanted to talk about the intersectionality of who I am, so I can understand where we're going with this urban. When I was asked to be in an urban panel, I was like, well, okay, this is interesting. I live in Dallas, Texas. I worked for 15 years in an agency in an LGBTQ organization that actually serves the LGBT community and those affected by HIV. And as far last year, I moved to another agency, very similar agency in Tarrant County. If you're not familiar with Dallas County and Tarrant County, it's 30 miles of separation. So again, talking about Tarrant County being an urban setup, I'm going to say that it's still in transition to be urban in many regards. I know I have the EHA director, manager here from both of those counties. And you can see even in the conversation that we had yesterday, how different in funding and how different you can see the outlook. I'm very pleased to be here with all these amazing individuals. I have worked with a lot of them in Dallas, and now that I'm in Fort Worth, in Arlington, it is very interesting to know some of the people that are doing the same work in an urban area, and also in an area that is in transition to be urban. I am a Mexican born, so I do speak Spanish. That's my first language. So I do see a lot of the need that is happening in Tarrant County, for example, to serve communities, the LGBT community specifically, and also the Latinx community. Dallas has probably an advancement of another 10 years. So going to Fort Worth is actually do the extra work that in Dallas has been done in the past 10, 15 years. So, and on top of that, I'm a nurse by graduated from Arlington, Texas, and I do see all those perspectives. The LGBTQ community, we still here. We are working really hard, but we know that we're in Texas. We still suffering. And I know that people are in DC, they're in LA, don't really have that impact. We still have a huge impact about what is happening in Austin. And we really feel it in communities. Living in Dallas, I used to be like in a bubble and not be affected so much because we have such a strong LGBTQ force there. But let me tell you, getting out of that little bubble, that changes. You go to Tarrant County, and yes, we have a very strong community. However, we don't have like the denominated gay area where people can be themselves and look for information about PrEP, or look for information about, oh, you know, I want to do an STI. So it is, I think that's kind of the perspective I can give in this conversation. I feel very, very humbled to be here with such amazing people that I have worked for all these years. I'm in my 16th year working on this field, and keep going.
Good morning, everyone. My name is Nathaniel Holly, and I am the executive director and founder of the Freelux Project. We're a Dallas-based Dallas community-based organization that was created with the mission to end stigma related to HIV. A big task, but it's something that we have done very well. And we do that by amplifying the lived experiences and the lives of people living with HIV, and also amplifying the services that are available to them, and no matter where they are. Even though we're a Dallas-based organization, we utilize social media as one of our primary methods of reaching people, and we've been extremely successful at that. We have launched more than 10 campaigns with over 4 million impressions online, and we have tested in almost every state in the country by providing our home test kit program and utilizing what people have in their hands today, their phones. Most people get their news from their phones. Most people get the information from their phones. And so we've been utilizing that as a tool to be able to reach as many people as possible, to shift the trajectory and how we talk about HIV. A lot of times we've been talking about the social determinants of health, but one thing at the Freelux Project that we do is deal with the cultural determinants of health by infusing a lot of great language and great imagery into people's minds about what living with HIV looks like, and also amplifying prevention services around where we are. And just to give a little bit more context about me, I am not originally from Dallas, Texas. I was born and raised in Dayton, Ohio, and I moved here after working in DC for 11 years. And a lot of the people around this table I know from my work in DC. And as a data person, when I moved to Dallas, the numbers and the data as it related to Black women were appalling. And so that is what caused me to get into action and also understand that, as they said yesterday, if Black women are the helm of our communities, if no one is helping them, then we will never get to ending the HIV epidemic by 2030. And thanks to my grandmother, Ora Holly, I make sure I say her name today because this is one of the biggest platforms I've ever been on, and she is the reason why I do this work. She taught me to not only speak up when you see something, but do something when you see something. And we continue to do that. And so I thank you all for being here, and I'm excited to have this conversation today.
Hi, I'm Sharice Morales-Greeny. I'm from the San Antonio AIDS Foundation, and I want to say first, thank you so much for the invitation. I'm very honored to be here on behalf of my organization, but also on behalf of the city of San Antonio. San Antonio AIDS Foundation, or SAFE as it's known, and that acronym is very intentional because we insist on being a safe space, was founded in 1986. We were the first ASO in San Antonio, and we've evolved over the years. We started as a hospice. Now we are an outpatient facility and provide wraparound services. I want to start with, as a public health professional, I strongly believe that the first thing you do to have an intervention is education. And while we think of the state of Texas as not having any sex ed, that's partially true, but I want to shout this from the rooftops as well as keep it on the down low. We provide sex ed in the schools in San Antonio. Now, it's generally one, thank you. I'm very proud of it and anxious to keep moving it forward, but I want people to know about what we do with education because that's been a big factor in how we've been able to respond in San Antonio. So it's one lecture. We start with middle school where it's age appropriate. It's a little bit about HIV awareness. And then we do another session in high school, generally sophomore, junior level, where we do an HIV STI 101 course. We have to start with abstinence is the main thing. But then we can go into why condoms are important, why lube is important, why anal sex is different from vaginal sex in terms of transmission. We discuss HIV, gonorrhea, chlamydia, and syphilis primarily, and how you can prevent them, where to go for testing, where to go for treatment. A lot of folks don't know that, especially the teenagers. We also talk about PrEP. So I said keep it on the down low in a way because we don't want to have people picketing at our schools, but we do provide this in two of our biggest school districts in San Antonio. There's actually 17 school districts, but 3 of them have most of the students, and we're in the 2 biggest ones and a couple of the smaller ones, and trying to go into more school districts that want us. We have to be approved by the school board, so once we have our presentation, we can't change it a whole lot, but it's really been a huge factor because most of those kids don't know that they can come to us for testing and treatment without parental consent from the age of 13 up. They don't know where to go before they hear from us. And we're finding that now when they come to us for testing, they're saying, we heard about you in school, or my friend heard about you, or my sister heard about you. And so they come to us. We're seeing a lot of youth come into our offices for testing, which is great. They're also testing positive, which is not so great, but at least they're knowing their status, and that's so important. So in addition to education, we provide testing. We do about 5,000 tests per year in San Antonio, both at our facility and then a number of outreach events throughout the community. We also serve some of the rural areas surrounding us. Before I came to SAFE, years before that, I was at the State Health Department in the regional office in San Antonio. So we served 27 counties, most of which were rural. So I'm actually very familiar with the issues affecting the rural population as well. So we also serve the counties directly surrounding San Antonio. And in many of those places, we're the only ones that are providing testing. And then they'll come into San Antonio for care. We provide, once testing positive, we provide linkage to care services. So we have an outpatient clinic on site. We have a pharmacy on site. We provide case management services. We provide meals, 3 meals a day, 7 days a week. We do about 3,500 meals a month for our clients. The meals are really important because they provide a community gathering spot. Occasionally, folks will drop out of care, but they'll still come for meals. So we'll know, we let the staff in the cafeteria know, hey, we've been looking for this person. We haven't seen them. They haven't responded to our calls. They've missed their last few appointments. If you see them, let us know. And so that we can go over there. And we do that with the other agencies as well. They'll ask us to be on the lookout for certain folks so that we can get them back into care. We have 3 different housing programs. We have a transitional house for folks that are currently experiencing homelessness. That includes a room set aside for transgender individuals if they choose to stay separately. We're the only ones that have that. And then we have a tenant-based rental assistance and permanent supportive housing, and also, of course, mental health support. So like many ASOs, we provide this whole wraparound service. And I want to emphasize that in a city like San Antonio, we're not alone. We have 2 other ASOs that are very similar to ours. And then, of course, the health department and some of the FQHCs in the area. We all work together very collaboratively and sometimes a little bit competitively, but we try to make that fun. But I really think that's a significant part of the success we've seen in San Antonio over the last 5 years from when we were a hotspot till now, because these agencies are working so collaboratively. So I'll stop there and pass it on.
Good morning, everyone. I am Antoine Wiley, better known as Mr. Community. I am the president and CEO of AIDS Walk South Dallas Incorporated. On last Saturday, we celebrated our 14th year anniversary. We started as just an AIDS Walk, and of course, there was no way that I could sit by for 12 months out of a year and just wait for another AIDS Walk to come around. And so we definitely have programs and services that we operate 24/7. And one of the things that we used to do testing, we used to do STI testing, we used to do all of that when we first started, but I said, no, we're not going to do that. There's people that already do that. Let's support those that already provide that service. And so we wanted to make sure that our organization created programs and services that were unique and different, focus on creative and things that were innovative. And so some of those programs, and I will say this because I'm proud to say it, this is my 37th year being a part of this community, doing the work of HIV. Yeah. I was telling one of my colleagues from Dallas, I said, no matter how long I've been doing this work, it's always the nerves that come up when it's time to speak. That is so insane. But I've also been living with, or HIV has been living with me for 32 years because I'm in charge of my HIV. HIV is not in charge of me. And so, thank you. Some of the programs that we do is the National Strength Conference for Men Living with HIV, which is one of our most successful programs. It started simply from a support group for African American men living with HIV. We were getting calls from men that were not African American, and so I said, we have got to create a space where all men living with HIV can come and receive support, empowerment, and education. And so 10 years ago, our 10th year anniversary is this year, actually, we created the National Strength Conference for Men Living with HIV. And we have men who come from all over the country to participate in this conference for 4 days. It used to be 3, but the guys talked me into it. They said, that's not long enough. We need more time. And so we expanded it to 4 days, a Thursday through Sunday. And I tell you, it is one of the most empowering, electric events that we have that happens with all of these men. And I really wanted to bring a focus to heterosexual men because we had heterosexual men coming into our spaces and they told us that they were forgotten, that no one was listening to them. So we make it a point to make sure that our space includes heterosexual men at the National Strength Conference for Men Living with HIV. I did not want it to just be about gay men. I wanted it to be about all men living with HIV. And I tell you, it's such an amazing experience. One of the other programs I talked about, our support group, which is simply called The Group. I didn't want it to be, I did not want it to be branded with nothing identifying. And so it's simply called The Group. This year in October, we will celebrate 18 years of this support group. Just getting men, yes, just getting Black men into a space every second Thursday of the month to just talk about their stuff is a job all by itself. And so I'm just so excited that these men continue to come, continue to show up, continue to be present, continue to share, continue to be empowered, continue to be to continue to feel supported. And one of the things special about this support group, one of the members told me when we first started October the 12th, 2006, he said, I do not want to be a number. He said, every organization that I go to already, I'm a number. I don't want to be a number in this support group. And so I've made sure that no one does a sign-in sheet, no one gets a gift card, no one gets a meal, no one gets a bus pass. You come for three things: support, empowerment, and education. And they have showed up. So it works. No dig to anyone who provides those things, but this is working for us in Dallas. Talk about one more program and then I'm going to move on. I like to talk about good stuff. The Wellness Roundtable, we celebrate 11 years this month. It was a space that I was working for a pharmacy. And of course, they wanted me to go out and find people to transfer their prescriptions. I said, I don't do that anymore. I don't do that kind of stuff. I provide education, I provide training, I provide opportunities for people to be empowered. And so while I was at that pharmacy, I started the Wellness Roundtable. And it was simply a space, because what we do at AIDS Walk South Dallas, we really focus on partnership and collaboration. And we want to make sure that we are present and participate at every organization in our city, not just specific organizations. And so the Wellness Roundtable provided a space for all organizations, including people living with HIV, to come together at one table once a month for education and to talk about what's going on in our community and identify services to serve the people that available for the people that we serve. And I'm just so honored to say that we meet every third Thursday of the month, and almost every organization in our city is represented in this space, showing that collaboration and partnership really, really works. Thank you.
So thanks to each of the panelists and the organizations that are represented here. We are going to do another sort of round robin, and I'm going to ask, starting with Antoine, you did such a good job at articulating, Antoine, the unique challenges that are faced by urban areas. And if you could highlight, in the previous panel, we heard about some of the infrastructure issues, the relational issues around stigma, the issues around decision-making. What do you see from an urban perspective as being unique challenges? And we'll go right around.
Well, I think I can echo, I'm sorry, it's kind of loud. We have so many. So you would think that being in rural would be a lot of issues, but even in our city of Dallas, we face a lot of issues. Housing being the biggest issue. Food deserts being another issue. Infrastructure being an issue. We talk a lot about ending the HIV epidemic. And one of the things that I say is, how can we end the HIV epidemic when there's so many people who still believe there is no epidemic? There's still people walking around that believe that HIV is gone, that we no longer have an issue. And so we spend a lot of our time still going back to the basics, educating people just on transmission, educating people about HIV. And so it's still so much work to be done to even get to the end. We're almost, and I hate to say this, it's almost that we have to go back to the beginning to get to the end. And one of the things that I heard yesterday that I thought was so amazing about reigniting the end of the HIV epidemic, going back and talking about from the beginning, talking about what is ending the HIV epidemic. Where are we at ending the HIV epidemic? What can we do to end the HIV epidemic? Like going back to the beginning to get to the end. Does that make sense? Yeah.
So San Antonio is often called the biggest small town in America. We're a city of 1.4 million and about 2 million in the county, and everybody knows everybody else. You might be 1 degree of separation. And in the LGBTQ community, it's even more than that. So stigma is definitely an issue, similar, not the same as in the rural communities, but there's still a factor. Can I go there? Can I go somewhere where somebody's not going to know me and I can be anonymous? It's very hard. We definitely have all the privacy protections in place, but that comes up quite often as well. People don't want to be seen associating with an STI clinic. They don't want their friends to know. They don't want their family to know. We actually see that with PrEP sometimes. Folks are hesitant to go on PrEP because they don't want their roommates or their families to know. So stigma is a huge factor. Cultural issues definitely impact us. Because of the familia, it can be very difficult for someone to come out and come out comfortably. And so people will come very quietly, and that's a huge factor. On the other hand, there's a great acceptance too. So once people are out and accepting, then their families can be the biggest source of support in our community, but it's sort of one or the other in a place like San Antonio. But I also want to say access. So while we are a city, we have a lot of different access points, we're still incredibly divided. San Antonio, if you look at the map and consider a circle, 3/4 of that circle have very, very limited access to healthcare. Those are our poorest areas. And our clinic is located in one of those, but it still can be difficult to get to, partly because of transportation issues and how spread out we are. But despite our education efforts, which are really robust, I think they're not robust enough, people don't know where to go. We recently updated our website, and when we did that, I became the person that receives all the emails. 99% of those emails are from people who have never been tested before, and they want to get tested and they don't know where to go, and they're asking the process, and that's all on our website. But I realized they want somebody to walk them through the steps and hold their hand a little bit. I even had one person messaging me saying, "I'm here in front of the building. What do I do now?" And I said, "You go in and somebody will be there to help you." But they were, and they thanked me afterwards, and they explained, "This is my first time. I'm so nervous. I'm so hesitant." So I will be honest, I was another email I have to respond to. But once I realized the situation, I said, let me respond. I was thrilled to do it. And I almost don't want to give it to anybody else on my staff to do it because I like having that interaction. It's a little bit anonymous, but I'm able to walk somebody through their first time. And we often start with chlamydia and gonorrhea testing. That's fairly new for us. That has been a game changer in our HIV diagnoses, because first we were supposed to do only men, and we had so many calls from women to get the gonorrhea and chlamydia testing. We just said, we're going to do it. We'll find the money. We're going to do it. And then our numbers of women coming in skyrocketed. And when they come in for gonorrhea and chlamydia tests, we give them HIV and syphilis. And so we started to see a lot more diagnoses of syphilis and HIV in women and in younger women. And it's because they came in for the thing that they were more comfortable coming in for, their first question, which was the gonorrhea and chlamydia. So one of our biggest barriers, and that's not unique to cities, is that most of the funding is focused on our priority populations, which for us are men who have sex with men and transgender women. And the funding isn't there for cisgender women, heterosexual men, which we never say no to anybody that comes in for testing. We don't necessarily go out and try to find someone just to get our testing numbers up, but if we're out in the community and you come to us, we will give you a test. But that's one of the challenges. Again, probably not unique to urban areas, but it's something we see quite a lot.
And if I could just add anything, those are great core issues: stigma, culture, housing, underemployment. But one thing, I would like to add a few more to that list, and that would be culturally competent providers. Huge issue in Dallas. Competition among providers, huge issue. I mean, and not just in Dallas, but in a lot of other urban communities that I know of. And one issue that is specific to Dallas that I've been working towards and try to flesh out is an inadequate prison to community pipeline. In Texas specifically, if somebody is diagnosed in prison, when they are released back out into the community, they may be given a 7-day regimen of medication, maybe, when they have nowhere to live. So what are they going to do after that week is done and they go back out into the communities where there may be 3 or 4 women waiting on them to come home? Let's be real. and talk about it. And so these are the conversations that we're having in our community. But I think that if we can ramp up the way that we rip Black men out of our communities and then throw them back into the communities without any services or help or any type of wellness check, I think that that's one of the other issues that we need to address.
Well, I don't think that there's a lot to add to that. I think it's great to emphasize some of the things that my colleagues had saying. Something that happens, I think, in a big city is displacement, and I think we talked about housing. Something that I see in the LGBT community is like it's moving out, especially in Dallas, and is looking for housing that is much cheaper. Again, if you see in the context of Dallas County and Tarrant County, you can go to a much cheaper area that is outside where all the services are provided. And you can see a lot of individuals coming to Tarrant County. I think somebody asking a question earlier about how immigration is happening. It is happening. We get a lot of individuals that are immigrants for Latin America. I think that they come to our doors and they're looking for services, first of all. And on top of that, if they're immigrants and they are gay or transgender, obviously it's very difficult for them to find the service. And they want somebody to speak their language. It's important to have somebody in the office that speaks Spanish. I think talking about STI testing, thank you for bringing that up. It was something that it was on my list. When I moved to Tarrant County to this organization we were serving, and my boss probably is going to kill me because I didn't talk about my organization. I work for a health center. We have 2 clinics, and one in Fort Worth and one in Arlington. And the work that we do, it's amazing. Pretty much you walk in our clinic and you get free services, free testing, free PrEP, free PEP. We offer a lot of PEP. And we're very proud to talk about how easy it is to get services. We go back to the same thing. We live in Fort Worth. Fort Worth is so spread out. People drive for an hour, 2 hours just to come to our clinic. Luckily, we also provide teleprep, which is something that is being a game changer. We have 5,000 people on PrEP, not only in the DFW area, but all over Texas. We get people from Houston for some reason. And it is important for people to have those options. Going back to those barriers, we still have to have more communication, especially like the LGBT community, people of color communities. I mean, they still need more information. They need to be walked out into their processes. And I think that we still have a lot of work to do, even with the social media. Some people don't look at social media. They don't even know what group to look. They don't even look where to. They just go to a Google. If you don't find something that appeals to you or in your language, or if there is an image that it looks like you, or somebody talks with you the way that you need to be talked, because somebody mentions something, especially about immigrants, the people, they're very smart. They just don't speak the language. And sometimes we feel that they're dumb just because they don't speak the language. So we have to be very careful how we engage in those conversations, because if somebody walks into our clinic and the big barrier is that person is not speaking Spanish, we have a problem as an agency. We have a problem as a health department. We have to be able to serve them where they are.
So we're going glass. All my panelists have said the things that I would have said, but one thing I do want to hone in on, I think we talked about access, we talked about education and capacity, we've talked about housing. And so I wanted to speak on housing, because right now my agency is in its first term of providing housing. And when we talk about housing and access and those type things, we think of being in our urban areas and trying to apply for those services. And a lot of our clients don't have up-to-date driver's license. They don't have birth certificates. They don't have a last bill in their names, because if you walk right outside of our door on MLK, the homeless, they're sleeping right up under our shed. They're sleeping right on our streets. And so to send them to get housing and expect them to have those things when they don't even have anywhere to store those things, even if they do have them, and they don't have the transportation to go and update those things when that needs to happen. And so what we are trying to do, and what we strive every day to create a red carpet service to where, yes, we want to house you, but we want to also not just turn you away when you don't have the things we need on our checklist to satisfy what HUD is asking us to have. We want to, whatever you don't have, we want to provide services to get you those things, so that from start to completion, we have serviced the clients. So I think that one of the core issues is just not just looking at the access that's available, but do they truly have access to what's available on all scopes from start to finish.
So Marquise, I'm going to start with you, and this time you'll go first and not last. And so I'm starting to hear differences in the urban areas, and I realize that we're using the term as if it meant the same thing across the different contexts here in Texas and across the country. But I wonder, I've heard reference to San Antonio, to Dallas, to Houston. Help us to understand differences in those cities as it pertains to HIV prevention and treatment.
I believe that each city is going to have a different priority need. And I think that what we try to do sometimes is box in. We look at it as urban, and then this is the list, and we want to satisfy all of those needs in one grant or one program. And I don't think that can happen. I think that if we just look where I'm from and where we do the work in South Dallas, that our needs are definitely probably different than the things that they experience in San Antonio, or the things that they experience in Tarrant County. Overall, we all have one mission, and we're trying to end the epidemic, of course, but we're faced with different barriers every single day. Again, we try to keep in our program, we try to keep all of our clients in care. We try to make sure that they come to their follow-up appointments. We try to make sure that we provide transportation and all these things to keep them in their continuing care. But that sometimes becomes a challenge again when the other needs are not met. We spoke about in Dallas, we're going through gentrification, and everyone is being pushed further south. Or you're either not going south, then you're moving north, right? But the price is moving north for housing increases, doubles what's being paid for in the South. And then as you go, if you think about what's right outside our doors, these are kids who have inherited grandmother's house. These are her uncles and things where grandmother's passed on and they've left this house, and now the house has been put up for foreclosure, and the house is now. And now the house has been sold and they have nowhere to go. So again, their priority is not healthcare. Their priority is not it's not their clinical appointments. It's just survival at that point. And I think that every city, whether rural or whether urban, is going to have a different survival process. And I think that how we deal with that as individual agencies and individual programs is going to speak to how we can really service our community. We can do some of the same things. We can provide some of the same services. However, we have to make them unique to the area and the cities that we live in.
Just as I mentioned before, I think that kind of connection of urban and suburban, rural. I think we're very used to use labels, and I was born in the early 80s. I like labels, but these new generations, they don't, and I get it because one day I can be something and the next day I can be something different. So going about the differences between urban, I think we just need to realize that there is a lot in between. And I speak on that perspective just where I'm located, because even though that I live in Dallas, there is a big difference when I see patients in Tarrant County. because these patients that not behave the same way that the ones that are in Dallas. So we have to be more cognizant about those differences. And then going about the person, you have to really think about the different approach with that person. What is this person coming from? What is the age of this person? What is the gender? What is the sexual orientation? Because everybody is very individualized. So you have to take care of those individuals as individuals, not necessarily because it's part of the funding, because you are in this city or you are in this county, which it happens a lot with when we sit in a table like this one, that we have a specific fundings for a specific area. So it's a lot of the conversation with the Department of Health about how important it's for us to diversify and not just be in our HSD, which is just Tarrant County, because our patients, our clients, they're not just in one place. We realize, like, for example, a lot of the LGBT community in Tarrant County, they travel to Dallas a lot of times. And it was the magic now is that a lot of clients come into our clinics and either in Arlington or Fort Worth because so many reasons. We try to make them feel that they're unique. I think somebody mentioned about that, not a number, in that they work in our facilities. If you've been in our facilities, we are very, very happy to say that it doesn't look like a free clinic, because you think that if you have a free clinic, you have to be a rundown office. No, we want for you to feel like you are in a concierge, and that everybody that is there is actually educated, culturally competent. I think that's so important, and not necessarily about where, if you're urban or not, you have to be competent. It doesn't matter if you are in a rural North Denton or if it's just Dallas or Fort Worth.
So Nathaniel, I'm gonna ask you a follow-up to something that you said earlier that I thought was super interesting. So you referenced, when you were talking about sort of urban areas and providers, you referenced issues of competition. And I wonder if you think of that as being something that perhaps is unique to urban areas, the competition among different providers.
I would say yes. I think that when you come into any metropolitan city where there's only one pot of money, and you have a number of organizations that are trying to do the same work, there automatically becomes competition. It's bred into the funding stream. And because of that, there's a trickle-down effect that disincentivizes community organizations from working together, because if I need these numbers for my grant, I need these numbers for my grant so that we can maintain funding. One of the unique things about my organization is that thankfully we came in federally funded. I didn't need the state. I didn't need the local government. I didn't need to have competition with anyone. All I had to do was do the work that I saw fit for the people that I was connected to. And in growing since that, I have seen a lot more collaboration in the city, in Dallas, and in other urban areas that I'm connected with, because we see that if we're going to end this epidemic, we cannot be disjointed. And that goes to the question that someone asked yesterday. Do we really want to end the epidemic? Or do we want to continue to maintain businesses that continue to maintain our lifestyles? I sit here as a corporate professional who uses my downtime to run a whole nother business. So when it comes down to it, Freelux Project will always run, whether I'm funded or not, because this work is needed. And that competition doesn't exist when you don't have to have it. And I appreciate all of my colleagues here, because we all have worked together here, specifically in Dallas, because we understand that without that collaboration, we won't be able to get to 2030, like Vincent said yesterday. And we need all hands on deck in order to be able to do that.
I like the discussion of competition, because in a city like San Antonio, so we have 3 ASOs and there's 2 major clinics, as well as some smaller clinics that are prep clinics that have come up, and there is one pie. That said, I think that we've, as a community, worked very hard. And a lot of it depends on who's in leadership at any given time, because those personal relationships are what matters. But our clients and patients have moved amongst all those organizations. They know everybody. And so our staff have to as well. And so it's ebbed and flowed over the years. But I think we're working very collaboratively. And one of the things that got set up about a year ago was a testing task force, where everybody that provides testing in the city gets together once a month to talk about what they're doing and where they're doing it. And if they're providing PrEP and how they're providing PrEP and what are the issues are. We are now putting together a housing task force. Housing is one of our big issues, and I can talk about that more later, but the housing programs, they work together, and what'll happen is depending on the grant, where it's coming from, one agency's fiscal year might be ending in September, but the other one doesn't end till February. And so, okay, can you guys take these 2 people for the next 6 months, and then we'll take them back after that? The person doesn't even know really what's going on behind the scenes, but we're able to move them because we're working collaboratively. And we're trying to set up the same thing with the case management so that everybody's aware of how they're all working together. And so it's hard to overcome that competition because it's still a little bit there. Like, you're not going to steal my patient, are you? And I mean, a lot of it is just stopping that language. Somebody said recently something about we need to steal their patients. And I said, stop. That is not the language we use. How can we support you, support our patients, and vice versa? And that takes a lot of personal one-on-one effort. And I feel very proud of our community that, for the most part, we've been able to do that.
So Antoine, I'm going to frame a question for you that builds on something you said at the start. You talked about the National Strength Conference for men living with HIV. And I'm curious, in Texas and in many places in the country, there have been attacks on people living with HIV, on LGBTQ plus communities. How have you responded in your organization to sort of getting the work done, given the context that you're working in?
I'm going to answer this question, but I got to put something along with that competition thing because I don't play those kind of games. I am the big mouth in Dallas. I shake the table because I don't believe in that competition because it's not about us, first of all. And I have to always remind organizations, it's not about you, it's about the people that we serve. They choose where they want to go. It's not a competition. And one of the things that I did many years ago is I started a report card. The person that wanted me to talk about this is gone, I see, but hopefully they're watching. I started a report card. And on that report card, I have a list of every organization in the city of Dallas that provides services. And when I refer someone to that organization, that client reports back to me on the service that they receive because it's about quality, comprehensive health care, period. And they report back to me their experience at that organization. And I have kept that report card for all these years. And I make sure that if the experience is not what it should have been, I follow up with that organization, however that looks like, because I'm not in competition. So I can say what I want to say. I can do what I want to do because the first priority is the people that I serve, period. We have lots of funding, and we're not in fear of it being taken by another organization. Let me just say that. Because one thing I have tried to teach organizations, especially being a member of the Runway Planning Council, we have to think outside the box in 2024. As Nathaniel talked about, it's this one lump of funding and everybody's going for. There's so much funding out there available. You just have to tweak how you serve. I'm not going to give you my recipe today, but you got to think out the box. You got to think creatively. You got to think innovatively, even if that means changing your mission statement, which is what we did. We changed our mission statement, which is more broad, where we can talk about where we can do blood pressure. We can meet those young men coming out of prison at the bus station when they're released. We have someone who is working on a program now for diabetes, because all of these things are intersectional. All right, and so it's about thinking outside the box. Now, your question: how do we meet the needs of I guess because dealing with primarily Black men, we really don't see those issues because the African American men that come to our organization really don't be out. They don't go to the clubs. They don't go to Cedar Springs. They don't do, which is our main gay hub in Dallas. They don't do all those things. They go to work. They go home. They take care of their families, and that's it. And so the other clients that I just really, we really don't see that. We really don't see them being attacked and all of that. And one of the things we have to do with the National Strength Conference, we have to find a safe place. So when it comes to hotels, we have to find a safe place. We promote the name of the hotel, but I can honestly say in the last 10 years of the National Strength Conference, we haven't had anybody to invade the space. Nobody's coming to peek. We have security at all locations. It's still very difficult to get guys to come into the door because there's still stigma, okay? It's still very difficult. We have more guys that attend the National Strength Conference from other cities and other states than we do from our own city, because it's still very difficult for them to walk into the doors, because once you walk into that door of that hotel and become a part of the conference, then you are now known as a person living with HIV. So it's still so much work to do. And one of the things we're concentrating on this year is having conversations with men in our city to let them know this conference is going on, to use the men that have come to the conference. Some of them are here today. I'm so glad to see them. I can't to tell you who they are. They have to identify themselves. But to really let them know what to expect when they walk into that space, so they know that they are coming into a safe place. Yeah, so stigma is still real. And I'm gonna give this example. The walk was we had our annual walk last Saturday. I tagged my son and his mom to say, oh, they're coming to the conference. My son began to receive phone calls asking, are you okay? Is something wrong? And my son was like, what are you talking about? And they said, we saw that you were going to an AIDS walk. So those are the kind of issues that we're dealing with. You can't even come to an AIDS walk without you being assumed that you're living with HIV. So it's still those kind of issues that still exist when you're talking about ending the HIV epidemic. The fact that you can't even support an AIDS walk in 2024. So yeah.
So if I could add something to that, just briefly. I was at the AIDS Walk, South Dallas, and kudos to you, Antoine, for the work that you've done and the representation that you've continued to maintain in the community. But I would be remiss if I didn't sit here and say that I'm a Black gay man that's been living with HIV for 12 years. And in 2024, that's still a revolutionary act to say that. And because of the work that you're doing, you are allowing other people like me to be able to stand on stages and to be able to declare who we are to the rest of the world, which ultimately create space for other people to be able to see themselves in a better light, in a better circumstance. So thank you for that work, and thank you for all that you do.
Thank you, Nathaniel, for sharing that perspective. So I'm going to open it up to folks on PACHA to please raise your name cards, and we'll start the Q&A period. We have about 15 minutes, a little bit longer. So if there are questions, it would be great if we could start identifying folks. Okay, I'm going to start on the left with DeAndre.
Yeah, so I want to Nathaniel, you being kind of like the new kid on the block here with your organization. What would you recommend, or what advice would you give another person who might be watching, or a young person who has come into this space, into this field, that wants to kind of take the same route and start an organization, or feel that they want to make a difference in some way, but there's so many larger beasts and larger organizations that are already out there, but they don't feel like there's something that's serving them? What advice would you give them to go forward and do that, or any tips you would give to that person?
Oh, yes. So one thing that I was remiss in saying is that in addition to all the programs that we also have an ambassador training program where we train health professionals and advocates around the country to do the same thing that I'm doing right now. I feel like we have to be able to be in the space to build capacity and build the next generation of leaders. And I don't feel like the last generation necessarily did that in a lot of ways. I feel like there was a lot of gatekeeping, and I feel like there was a lot of ways where the new community and the new kids on the block were necessarily locked out of a lot of rooms. And thankfully, I don't attribute to any of that, because I'm a Leo. So, I do what I want to do when I want to do it. And none of that ever mattered to me. And what I would say to them is reach out to me. There are so many different mechanisms and ways to build capacity. And with the understanding that your story has so much power. One of the things that we do at the Free Lux Project is we empower and amplify the stories of people with lived experience that can actually help the health outcomes of the people that are around them. So that one person can affect 3,000 people. Like, and you knowing that if we had that one person in each community around the country, we could end the epidemic. And one thing that I always tell people is if we treated HIV or the HIV epidemic like COVID, it would be done. It would be over. Unfortunately, we don't see ourselves in the epidemic. Many people don't see their family members in the epidemic, and that is one of the biggest barriers to us being able to be in care. So the more people that we have in local communities to say, I want to take a stake in ending the epidemic, the more we will actually have the momentum to actually do so. So if anybody is looking towards becoming a CEO or a founder of their own organization, reach out to me, Nathaniel at freeluxproject.org, and I will walk you through every process that I went through and also show you how to stand up against the big dogs, because, you know, you can do it too.
Can I just...
DeAndre,
I
wanted to add to that.
Go ahead. Do your thing.
I think yesterday, it was yesterday, they talked about there used to be opportunities for teaching new leaders. And I want to shout out to one of my mentors, as you guys did on yesterday. I'm going to shout out mine. I want to shout out to one of my greatest mentors, the CEO of NMAC, Paul Kawada. I said I've been doing this work for 37 years, but the first 15 or 20 years, my work was mainly with National Minority AIDS Council because they created spaces for leaders. They taught leadership, they taught capacity building, they taught technical assistance. And for those first 15, 20 years of my career, I got a chance to go to NMAC, travel around the country and learn how to be a leader. And I think if more organizations, especially national organizations, would incorporate those kind of programs again to teach us how to be leaders. One of the greatest programs NMAC had was the POC, even before Block, was POC, which was done by the legendary Jacqueline Coleman, where we would travel around the country as people of color and be in rooms for 5 days where we learned true leadership, what that looks like, how not to compete against each other, but really come together and work together and get more done together as one versus these separate entities. So thank you, Paul.
Thank you.
Mackenzie?
Thank you so much, Vincent. And thank you, everybody, for being on the panel today. Nathaniel, it's so cool to see you in this context. When I was first sworn into DC's Ryan White Planning Commission 6 years ago or so, Nathaniel was on it with me, and it was cool to get to see him there, and it's awesome to get to see you over the years in here as well. So thank you. And congratulations to all of you on all the success. Nathaniel, I loved, you highlighted for me an enormous gap, which is returning citizens coming back with a week of pills and maybe 3 or 4 partners waiting for them. You know, it's a huge risk opportunity. It made me think that about working back at DC Health with the team there about doing something about it, but also it made me think about it would be a good opportunity perhaps for a federal RFP to fund facilitating that transition back into the community and help to make sure that their healthcare coverage is taken care of, so there's no gap there as well. So thank you for highlighting that.
Of course, and if I could add anything, I think there was one question that was posed to us that I want to make sure that I at least address is what can PACHA do to help us locally put out more federal RFPs so we don't have to go through the state. That part, okay? That would help out so much. Thank you.
If I'd like to add a little bit about that, because a couple of years ago we realized that was happening with the prison system and people coming out. So we started early intervention services program that was not funded, and the person that started it decided to veer off a little from that and focus on TDCJ, and so developed a relationship with the folks at, I actually forget what that stands for, but it's the correction system in Texas. I started a relationship with them, and so now pretty much anytime somebody is released in the South Texas area that's living with HIV, they get referred to us. And we have one individual who has a lot of clients right now, but then is able to help them through the process and get them enrolled in care. And if initially it was confined to Bexar County, but then we were able to expand it across the state. So he'll be the first point of contact. And then if they're moving to El Paso or Dallas or whatever, he'll connect them to an agency there. And that really has been a game changer. And not just providing the meds and getting them into medical care, but getting them enrolled in GED programs or helping them to transition back into the community. And this really was the brainchild of one of our staff that wanted to make this happen and kind of ran with it. Then we were able to go back to the Ryan White folks and say, hey, we're doing this, can you fund it? And they agreed to kind of mid-cycle because it was so unique and it's been really effective.
Thank you. So we have about 10 minutes left and there are 4 people in the queue. So the order that I have is Leo and Paul, then Daryl, and then we're going to swing back to Marvell. So maybe we could take, Leo, your sort of question or comment, and then also Paul, your question or comment, and then we'll have the panel respond.
Great, thank you. I just wanted to follow up on what Nathaniel started. I wanted to hear from the other panelists about your needs. You have PACHA here, you also have CDC, HRSA, and other partners here. So just wanted to hear from you all about how we can help you. Thank you.
Antoine, I just wanted to say hi. And thank you. And it is so amazing to see you, and it is so amazing to see all of you up here. And I'm going to make this very quick because there are many, many donors sitting in this room. And to all the federal donors, you have to make an investment in community. You have to make an investment in community. If we do not develop this next generation of leaders, we're really going to be screwed. And so, Antoine, thank you so much. And to all of you, thank you so much. But just remember, I did not pay them to say that, but the check will be in the mail.
I would like to kind of address what Leo was saying earlier. I think that there is what do we need? We always go to funding. But I think representation matters. I'm very happy to say that I'm a first Mexican-born person that it's in a leading position, a directorial position in my agency. And we're not a very large agency, but it was the same in the agency that I was before in Dallas. And representation really matters. I think the conversation of having people that are different from just what it has to be in a directorial position, a manager position. I think it is important. I think the conversation sometimes doesn't really happen just because obviously you have to think about how the abilities of or skills of somebody can fit in on a position. But I think it is important, and it goes all around of what Natalia is saying, preparing people to take on these jobs, because we continue to see the same leaders on those positions, and obviously there is no moving forward. So I think creating that conversation, training people, I think it is important, knowing that they have the capacity to actually be on those positions. I think it is important to believe in them. I have to be very proud to say my boss took a leap of faith on me, and it's been great in the past 6 months. 8 months that I've been in that agency, but I'm very unique. There is not really a lot of Latinos, even Mexican-born, English as a second language in organizations. Unless that organization, it is specific for Latinos, which in Texas, I think is 1 or 2 or 3 agencies in the whole state. We were talking about Latinos yesterday, and yeah, there's a lot of organizations in the South, but at the pension, one of the person mentioned yesterday, that border is going up, and it goes all the way to Dallas. So it is important to keep that in mind. Our trans folks that are getting behind. And even worse than Latinos and LGBTQ individuals on this position. So I think training and, of course, having that conversation, PACHA, if you can have that type of groundwork, it will be great.
Thank you.
Viva Chihuahua.
And one last, my response is, I think we heard it again yesterday. It was so much good information yesterday. But stop believing that because the organization is small that they don't have the capacity. Stop believing because we're a small organization that we don't have the capacity to fulfill the grant. Because, and I'm gonna just shake my own table. AIDS Walk South Dallas does more work than some of the, as in the words of Nathaniel, I put it on Nathaniel, the big dogs. We see more people, we get more people into care, we keep them into care, we link them to care, we get their needs met more so than some of the other organizations. So I think it's only fair that you give us a chance. And if you want to include capacity building into the grant because you think we don't have the capacity, that's even better. But just to think about us because we can get the work done as well.
Thank you. So Daryl, you have the next question or comment, followed by Marvell. Final question will be DeAndre.
Could I add one more thing? Sorry, just before that, about what we need. And I was really excited yesterday to hear that there was a session on women getting access to PrEP. And yes, more money always, but if we can get CDC and the federal partners to be more inclusive of priority populations or remove priority populations altogether. We don't want to wait until our numbers are so high in women that, oh, now we have to do something in response. We want to be able to bring women in, and we're doing it anyway, but we want to be able to not feel like we're going to get dinged for it because we're doing more women than MSM.
So I will extend my thanks to the panel as well. Couple of comments and a question. As an academician, as a president of a university, I'm kind of saddened that I don't hear more partnership collaborations with higher ed institutions, particularly public institutions that rely deeply on communities to get their research done. I'm a bit concerned that in the discussion, I'm hearing that people felt left behind. I think my first HIV conference is in 1986 as an adult. Many organizations and leaders have come and gone over the years, and the story is the same. In 1990, we prayed for an end of the epidemic, and our organizations were in business to put themselves out of business. It's 2024. What is happening? That we are creating a wheel that keeps reinventing itself. And so my question to the panel is, what do we need to put in place to stop recreating the wheel every generation, because we find ourselves losing ground? And I think to bait the question further, how do we codify the things that we're asking for so that we're not looking to CDC to make it happen, but we have more Ventons in place to make it happen? Thank you.
I think we have to evolve. We continue to do the same work with the same mechanisms. And I'm sorry, but when it's about government, we are behind 10 years. You guys are behind like 10 years because there is this slow response about, oh, let me ask, what is the community needing? And then that has to be approved, and then it goes back to you. So we are in the communities. We're like, no, we're not there. We're not there. We're already over here, and our communities are evolving. Our populations are evolving. It's not the same population that we had 20 years ago. So sorry.
It is an evolution, but the human estate is still the human estate. And we're talking about the very same situations. We're talking about the transmission of dis-ease, not just diseases, but dis-ease with well-being and health. We've created trauma-informed health and physical behavioral health response systems. We don't do wellness, and we really don't have an agenda to making communities and people well. Let's be clear about that. We perpetuate illness-based approaches to what we say we want to accomplish. And we talk about shifting our mindsets. The mindsets, and I agree with you, we talk about the government is behind, but who's the government other than the people? Elect the friggin' people you want in place to make the decisions that you say need to be made. Step up for all of us to do this work.
I just wanted to address the academic partnership element. We at San Antonio AIDS Foundation, we actually have a number of academic partnerships, one of which, Abounding Prosperity, is on the same program with Columbia University. And we're approached all the time. We have a few others that are bigger, but the funding is an issue. So a few of them that we have come with money, but we're approached literally every week. Will you sign on to this project? Will you do all this work? What do you get out of it? Oh, your name might show up as a thank you in the paper that we publish. And as a one-time academic myself, I've said, no, give us the money, give us our name on the paper, give us our transportation to the conference that you're going to present at, and then we'll do it. And I want to do it. I was saying yes all the time. And then I was like, we can't do this. You're asking my staff to do all this work and you're not giving anything for it. So it's really getting academic partners to start writing us into the actual grant.
Vincent, can I just weigh in on the questions that Daryl just proposed really quickly? You talked about reinventing the wheel and the things that we can do differently, and having folks in this room or wherever they may be to step up. But I think that the issue is that we have leaders who've been doing this work in the same place for 30, 40 years who won't step back. So that's an issue for me, is the fact that before I can step up, you have people who have not removed themselves and allowed young people to come in with our innovative ideas to step up. And you have pharmaceutical companies and the government funding those same organizations who really haven't made a difference or a change yet. I'm tired of going to the same conferences and doing things over and over where it just becomes a discussion, but there's no action items to go forward from that. You have new organizations and young people who are telling you what we need to be successful, because the things that worked and that were taught in 2005 won't work in 2004. We don't learn the same. We don't lead the same. And oftentimes young people do get blacklisted for not listening to our elders or taking the route in which they've instilled in us. But that should not be the case. And when we speak up, that's when we do see that we get blacklisted. I've experienced it myself for not going that route. I've had people at this table tell employers not to hire me. But what I've learned is that what God has for you, it is for you. So it doesn't really matter what they say. But that's the biggest thing, is that we have to be innovative and allow young people and new organizations to do something different, even if it does not align with what the funders think should happen. Be open-minded and allow us to come into a space and tell you what we need to end the epidemic at this point.
Great.
My thoughts.
Thank
you,
guys,
DeAndre.
we are at time, but I would like Marvell to ask his comment or question and wrap us up, and then we'll close this part of the day.
We only have time for one person to probably respond, but what does syringe exchange programs look like in Texas? Do we have... All right.
Is this being recorded, or are we being recorded?
No, guys.
All right.
Guys,
Okay.
we have a grant for that.
Let me ask a different question. Let me do it in a different way. Do people have access to fentanyl strips and Narcan in Texas?
Yes. So San Antonio AIDS Foundation has a grant from the Elton John AIDS Foundation with Corazon San Antonio, which is an organization that works primarily with the unhoused population that does substance use outreach. And a significant part of that is syringe exchange. They were at one time the only ones in Texas that did syringe exchange. I'm not sure if that's still the case, but that's huge. And Elton John Foundation was so excited to fund that. They're like, let me help you write the grant so that we can give you this money.
I'd like to take a moment just to thank the panelists from the Urban Group. Thank you. And also a round of applause for the Rural Group from earlier today. Thank you very much. So we're going to break for lunch and then come back for PACHA-to-the-People. But before we end, I want to just convey that Marvell spent so much time conceptualizing and really being the sort of brainchild here of this particular activity from this morning to now. And so just if we could recognize you, Marvell, and just thank you. Thank you.
Produced by the U.S. Department of Health and Human Services.